Okay, now, so let's take a quick look at a maxillary premolar. It's a second premolar that had a large carious lesion that came in and required to have emergency care. This patient was in a lot of pain, and we had to fit the patient in order to. It was in between patients, not a lot of time here involved, and we did a diagnosis, obviously, as it's very important to do first, to have a pulpal and an apical diagnosis. And the pulpal diagnosis was symptomatic irreversible pulpitis, and the apical diagnosis was symptomatic apical periodontitis. So let's take a look and see how it goes. We're going to start this from basically right from the beginning. You have a large carious lesion on the mesial root, and obviously you have to do your full diagnostics here. We've done our pulp testing and everything to arrive at the proper diagnosis. You can see that this patient had a composite, an MOD composite, and ended up having a large carious lesion underneath the mesial aspect of this composite. We see that quite a bit. If the composite isn't properly sealing, they end up getting decay under it. So to anesthetize these maxillary second molars, this patient is upside down because it's shot through the microscope, and that's why it looks like that. But it's a maxillary second premolar. First give the apical shot, then you wait a few minutes, about 5 to 6 minutes, and now it's time. I give also a intraligamentary injection. I don't go ahead and give the injection at the apex off the bat. I give the buccal injection first, wait 6 minutes. You get a little bit of a cross anesthesia up at the gingival level, and then for the lingual aspect of the tooth, all I need to do is to give PDL injections, and that saves the patient a lot of pain where they already come in pain. You don't want to get that palatal shot in the greater palatine nerve there. That's a painful shot itself. So you really have to treat patients that are in pain with kitty gloves and make sure that you're all the way from your just demeanor as well as your anesthetic, that you are as painless and as gentle as possible. So we're isolating this tooth, and because I have a lot of carious areas in the mesial area, I'm doing a split dam. I'm doing the split dam so that I can remove the carious lesion in the mesial aspect of the tooth without it getting, without my burr getting tangled up in the rubber dam. So you can do a proper, multiple kind of holes, and then put your thing through, put your floss through each one of these things, each one of the holes. But this is just a little bit faster to just do a split dam and pull it over. Now here I'm now using the 1558 Sabre cut from the Real Endo Access Kit, and I'm now quickly removing the composite and starting to remove the decay. Any seriously unsupported enamel is also being removed. And this is really important to make sure that all decay is removed. On an emergency procedure, you don't want to just go in there and do your pulpotomy, not pay any attention to the decay, because at the time of your emergency procedure, you're also trying to figure out if this tooth is salvageable or not. So your decisions are not merely to get the patient out of pain, but also make treatment planning decisions about this for this patient for the follow-up. So removing all the decay, in my opinion, is really important in this at this time, and it could be done nowadays very quickly. Here I'm now using the number 4 round burr on the Forza electric handpiece, and you can see that it very quickly removes all the decay because of the good torque that's involved. The ultrasonic, the Forza ultrasonic here is with the water very quickly removing the debris that's remaining, and you can see that I have the pulp horns. So once you have the pulp horns, always a good idea to give it a little bit of an intrapulpal here. The patient should not feel this intrapulpal at this point. This intrapulpal is a security deposit, if you will, on making sure this patient has a completely painless experience.
So it's for you.
It's for the patient, but it's for the patient, but it's also for me to make sure that I come across as the hero at the end of the procedure, exactly. So the anesthesia doesn't wear off and everything is working out fine. You find out that you have good anesthesia by doing your endo ice testing before you get started. If the patient feels anything, you are not ready to get started. So at this point now, we've removed all the decay. Now I'm just flattening the cusps. And now what we have is what we're going to be using here to do our pulpectomy. So I'm now using this ControlFlex stiff file here to just go and find out what's my available length. Available length is, how much of a canal space that I have, which is great. So I have a good 19, 20 millimeters here. Now I set that length on my expediter. That's the 1505 expediter file in the ESX system. And I'm just doing, usually, ideally, I just want to do single strokes and then wiping the file. That's the SSC motion that I'm talking about. And just moving down. As long as I have that size 10 confirming that length that it can go to, an available length that doesn't require any instrumentation, my Expediter can usually follow that. So just going again with single strokes in each, and then every now and then I use the ultrasonic and water to very quickly remove the debris. I don't need to use hypochlorite at this stage of the game because all I'm doing is just removing the debris that's been cut. So at this point, I have had the Expediter into the 2 canals that are in there, back and forth until I've reached close to that 20 millimeters mark. And now I'm using the size 25 ESX finishing file, and you can see again in the same motion of SSC, single strokes and clean. I do a couple of strokes in each canal, and you can see that it's moved down pretty close to that available length that I had. Now I'm ready to put the calcium hydroxide. This is the calcium hydroxide. This is the injectable type. You could use the injectable type. You could use the mixed material, use powder and water, and you mix them together. If you can use the injectable type, don't go all the way down to the apex. So what I do is I put in some in the middle root, part of the root, and then I push it down with my file. It's very important not to get that locked in. I've seen a lot of people have calcium hydroxide accidents by putting a lot of calcium hydroxide past the end of the root, and that can be avoided by merely using putting the material up on the coronal half, injecting to the coronal half of the tooth, and then pushing it down with your file. And then I'm putting in my putting a little bit of a sterile, dry cotton pellet in there, and put a little bit of a cavit on top of that to get the seal. So the question always is, well, have you removed all of the pulp from that tooth? And usually the answer is you don't have to remove all of the pulp. The key is to remove the critical concentration at the proper width. For a tooth like this, a size 25 would be enough, and especially with the kind of resistance that I was feeling as I was going down. So I got down to a good 20, I cleaned about 20 millimeters length. Maybe the length of this tooth ends up being 21, 22 millimeters at the end based on the estimated length that I had. But, as long as you're within a couple of millimeters of the apex, you're in good shape. So this is a little trick so that you can put your cavit in there without using a matrix band, by using your DG16 where it's kind of touching the cavo surface margin of the tooth on the mesial aspect so that you remove all flash. And then that, so you're just cleaning out any flash that's there. And then you just take your Q-tip and then you mold the cavit to close the margin. And that's a very, again, another quick trick to put your temporary material in there without having to use a matrix band. So that's basically it. And this is the second appointment is done, and this is a tooth that's now obturated using the SX hydraulic condensation. There's a post space on the lingual canal. That's why it looks a little bit weird. But there were 2 canals. There were 2 joining canals, and there's a little bit of a space in the lingual one for the post that was used. So this is just kind of a quick demonstration of how quickly we can do. This was hardly there wasn't much editing. So within 10 minutes, you can actually do these procedures efficiently using a couple of files, such as in the SX system. So let's come back now, Dennis, and talk about some of the required postoperative care for these kinds of emergency patients. Okay?
Very good.
Terrific.